Hi everyone. This is the video for the final case presentation for this for our subject for neuromuscular reeducation. So my patient is a lower quadrant case scenario. The patient is a 46-year-old male with a history of low back pain. The pain started after doing some yard work, cleaning his garage. Denies feeling any pap or any kind of sudden pain, but the pain was more of a gradual onset. Got worse the next day. Patient was managing the pain conservatively at home with some pain medications, but has noted increase in pain, which has subsided but is still ongoing. We're now about 4 weeks post injury or post complaint of pain. He denies any sudden other incidents of trauma in this case. So just a quick background about this patient. The patient reports he has other experienced low back pain in the past, which is similar to this current onset. And he usually just manages the pains with just over-the-counter Tylenol, ibuprofen, anything like that, and usually calms down within a few days. However, this recent pain has been going on for a few days now and doesn't seem to let go. Denies any real, significant medical history except for just a hernia repair, laparoscopic hernia repair about 6 to 7 years ago. He's a very healthy female, a healthy male otherwise. In terms of denied any bowel and bladder, sensory issues, or saddle paresthesia, any of those. So all the red flags for him were negative. In terms of lifestyle, he's a very fairly active male, plays recreational sports with his kids, and works out about 2 to 3 days a week, stands a lot for his job, works in healthcare field. Does have a history of idiopathic scoliosis since probably his teenage years, he mentions, and that is all about his medical history. So in terms of findings, some things that were very evident with I did a whole lower quadrant scan, and I'm going to kind of just discuss those findings with lower quadrant scan. The provisional diagnosis, of course, here is low back pain, which is fanning from his lumbar instability. And the reason I just said lumbar instability because everything neurovascular was negative. So slump, SLR was negative, spinal compression, all of those were negative. His reflexes, bilateral lower extremity is present and are symmetrical. Sensation was intact, no issues with sensation in both lower extremity. Now going to our active range of motion and those findings. So trunk flexion was fine. However, just coming back from flexion, a little bit of deviation in axis, and just slow return to flexion. Extension was okay. He was a little bit apprehensive going into extension, but otherwise it was okay. Side bending relatively okay. Has smooth curve going on the right side bending, a little limited in the curve going with left side bending. And axial rotation was unrestricted otherwise, except for a lack of presence of smooth S-curve with left rotation. So this kind of just going from here, it tells me, hey, left rotation was restricted. In terms of curves and side bending, there was a lack of C-curve to the left. Then I went into the biomechanical examination and findings, and some of the most first things that I did with biomechanical was the H&I test in weight bearing, presented with inconsistent findings. There was blocked in moving with one direction, for example, starting with one route versus the other, extension versus side bending. So definitely inconsistent findings. And then the non-weight bearing test were I did the prone lying test just to see, hey, is it really lumbar extension was limited or not? So I had him do like a cobra push-up going into the Sphinx position, and he was fine. He had increased range of motion with lumbar extension with some minimal pain at the end range. One thing also I did in standing was the sacral kinetic test, and noted that that was positive for the contralateral, so for him, the left side was positive, extension in standing was positive, and ipsilateral prone kinetic tests were positive. Did my PIVMs and PAVMs, noted increased mobility for extension at L4, L5, and confirmed it with PAVMs as well. Going further from there, the stress test. AP stress test was positive for increased mobility at L4, L5 at 70 degrees of knee flexion. And then, however, going into 90 degrees of hip and knee flexion, sorry, not knee flexion, 90 degrees of hip flexion, along with TA bracing, the stress test was negative. That indicates that, hey, there is lumbar instability, but we do have good prognosis here because he was able to stabilize the segment L4, L5 with TA activation. Just going through the findings so far. So now that I've done my quick assessment on the patient, I've come to a conclusion that it's definitely the pain in the low back is from a lumbar instability, given that all the dural sensitivity tests were negative. And it's now that we're 4 weeks post-injury or post-pain onset. So some of the assessments that indicated were going really towards a right-sided lumbar instability. And the findings that I discussed, the side bending curve, rotation, all of those were restricted, weight bearing versus non-weight bearing findings. Now, as we all know, with the classic findings of lumbar instability, the right side low back is painful, definitely sensitization of the right iliolumbar ligament. In this case, it was still minimally sensitive when I tested initially. So one of my first original treatments was just ultrasound for 5 minutes at 10% duty cycle. So I did that for the first day of the pain management. Now going into the other findings of right lumbar instability with right psoas facilitation. As we know, right-sided lumbar instability with right psoas being facilitated, it restricts the left side bending and right rotation. Right side bending, right? Yeah. So what I found that it is a left on left anterior sacral torsion. The right innominate is anteriorly fixed. And the left glute piriformis muscles were inhibited. Now, as we know, if we could work down the kinetic chain, this patient did not have any leg symptoms, but if we went down, it's highly likely that I'm going to encounter some of the other things that could go down the whole kinetic chain. And I found that just his gait assessment, how he was walking, weight shifting, and loading, there's definitely some inhibition going down the Pescenserine and early medial foot loading left, which is also, tells me there's definitely some tibialis posterior on the left that's inhibited. And as of now, he's okay, but if this continued, we could likely land up into a periostitis of the first metatarsal. And that could lead to a heel in the bunion that we, often see in a long, old instability. So now going into treatment, I want to run through the treatment quickly before I show the exercises that are followed up. So the first treatment that I started with the SI joint. And I wanted to first address the innominate because this is where everything's fanning from. Since the innominate was fixed, I went into posteriorly fixed. I went into the manipulation of right innominate into anterior rotation and prone lying, and the muscle energy, followed by muscle energy techniques and exercises to follow that. The second one was correcting the torsion. So right-sided instability led to a left-on-left anterior torsion. So I worked on correcting the torsion exercise, the torsion. My third go-to here was, once I did that, I wanted to, check the TLJ to see, hey, if there was a restriction and not. And as soon as I took him into a TLJ, because of the old scoliosis, there was a little bit restriction. So I did the manipulation for TLJ to improve the right rotation at thoracolumbar junction, and followed by facilitation exercises to maintain that TLJ. during that same, right, when the person is left side bending, left side lying, and I'm doing a right TLJ, it's also facilitating the opposite psoas here, which is the left psoas. So that was another one which is very important here, because since the right psoas is facilitated and the antagonist, that's the left psoas, is inhibited, this would be now facilitating the left psoas as well. These were the most three important things that we worked on. And going to the inhibition of left glute piriformis, there was some hip mal tracking as well. But since we did correction of the sacral torsion, that fires the left glutes as well. So, but anyway, since he had hip mal tracking, I did go ahead and do the hip mal tracking manipulation, followed by facilitation exercises for the left glute and piriformis. And once these four were done, my next go-to was just the core stabilization exercise. So the goal here was to fire the pelvic floor, fire the abdominals. So I went to the route of doing the psoas crunch that we kind of learned in the Aspire, and I'll demonstrate that in a little bit. And the last one that I had him do was the universal exercises with the band hooked up on the top, and then doing the universal exercise. My next video, I'm going to demonstrate all the exercise. Thank you.